And so our speaker for today, Dr. Hassan, he's a prosthodontist recognized by several associations and societies. I've already spoken a lot about him last time, and I think we can fill one whole hour with what he's doing and what he has done in the past. He's a researcher with over 50 publications and an experienced speaker in international venues. That's why I'm very happy to have him here today. He has also founded the Triodontics Academy for the Modern Dentist, and he teaches courses. And as I said, if you have missed the first webinar, feel free to go on the Morita YouTube channel. There will be the recording also from today. And now I will give the word already to Dr. Hassan by asking him if he would start telling us his great story about opening his clinic and purchasing the first Morita product.
Thank you, Sarah. Thank you for having me again for the second time, for the second webinar. Maybe first I'll start to share my screen. Let's see. I think this should be the way to do it. Can you see my screen?
Yes, we can see it, Bassam.
Fantastic. Well, thank you for the kind introduction. Now, good evening, everyone. Like Sarah said, I have a little bit of story to tell about how I started my practice. Like most people who start to work in implantology field and prosthodontics, I mean, you spend many years in training. You go to university, you follow master degrees, you follow programs. You don't really have time to work on your own practice if you're really dedicating yourself, or let's say, the first 10 to 15 years to mastering your craft. So for many years, I didn't really think about opening my own clinic or having to deal with administration. I still hate it, but you know, that's life. I mean, at a certain point, you grow to a point in which you have to really start to work for yourself. And we did open a practice 4 years ago, me and my wife, in the suburbs of Amsterdam. And like attached to it was the Triodontics Academy, where we provide courses for digital dentistry, implantology, but the emphasis is like on complex prosthodontics, digital implant prosthodontics, as we say. Now, the academy and the practice and everything, we got like any new startup, we started with 0 patients, and we got this big loan from the bank to start the practice. And then, as you can see, it looks quite nice. Now we have even a better reception area. Instead of these chairs, we have beautiful sofas. Took 4 years to be able to buy the sofas, and nice reception, everything, lights, floor, ceilings, you know, but we had no equipment. And then usually when you open your own practice, the first thing you start to buy are the hand pieces. And in my case, I actually bought 2 things. The first thing I bought was my dental chair for my room, for my office. And the second thing was the home beam CT scanner, the Morita ViewView X800. And at the time, it was considered crazy because I started with 0 patients. And I had no idea if this is going to work or not, to be quite honest. But for me, it was very clear that I spent so many years of my life studying prosthodontics, doing courses in implantology, doing master's education in implantology, surgery, prosthodontics. I'm going to be doing most probably prosthodontics and implantology. And I was thinking that it's a very big chain, the digital workflow we have. I still need to buy an intraoral scanner. I still need to buy a printer. I need to buy a mill unit. I need to think about the digital workflow. But for me, the thing that like jumped immediately to mind, I need to have a cone beam. And the reason for that is quite simple. If I don't have an intraoral scanner, I can still work. I can still take an impression, conventional impression. I will be a bit, let's say, less efficient, but I can still work. Do I need an intraoral scanner? Of course. Did I need an intraoral scanner at the time? Absolutely. But could I work without it? Yes, I could. And the same thing for the printer, same thing for the mill unit, same thing for all the other things in the digital workflow. The only thing in which I thought like it's impossible for me to even imagine working without was cone beam. Because for many years, I was a traveling implantologist. You know, those guys who travel, have like their own big luggage, and I have like these big bags with trolleys and pushing them around, going to practices, placing implants, going in once a month, once a week, once every red moon. You go in, you see a panoramic X-ray, and you nod your head and you tell the patient it's going to be all right. You open and it's a disaster. And for me, I said, if I'm going to be working with implantology, I need a cone beam. And I said, I don't want to have any cone beam. I want to have a Morita. And why did I want to have a Morita? Very simple. Cone beam CT scanners are quite expensive. They are large investments. I don't consider a cone beam CT scanner like an intraoral scanner or like a printer. It does not have a life cycle of 2 to 3 years. They are not easy to replace. If an intraoral scanner breaks down, you call the dealer, very angry on the phone. The same afternoon, they will run to you. They'll bring you a replacement device. A printer, you can say something. A cone beam CT scanner, it's even, I mean, I know only like 1 or 2 practices in the Netherlands who have like 2 scanners, but like most practices have only 1. And if you have a scanner which breaks down, it's a huge disruption to your workflow for 4 or 5 days before like everything gets fixed. Sometimes you need to order like some stuff, some replacement parts. So I want to have a reliable hardware. And why is this more reliable? How do I know that the monitor is reliable? Well, it's very easy. When I entered the department in the university in 2007, we had 2 systems. We had the Morita and we had, and I had no preference to each one of them. The only thing I had is that I need to work. And we had a very high volume department, many X-rays done because it's a university department, many patients, and lots of supporting staff. And the Morita guys, they came once a year, did some maintenance, some calibration, and then they left. No one heard anything from them. I didn't know their names. I didn't know if the machine is good or bad. I just knew that, you know, they came once a year, they did calibration, and they left. The other one, on the other hand, every like 4 or 5 months, I became very good friends with the support. I knew their first, last name, children name. I knew like where they dined, where they lunched. I had them on speed dial. I had messaging with them because the machine kept failing every other month. And when I left the department 12 years later, the Morita was still going strong. Nothing changed, while the other machine just kept giving issues every 6, 7, 8 months, once a year, too many repairs. Now, are there other machines on the market which are as reliable as Morita? Probably. Do I want to find out? No. That's the only machine like in which I already have, let's say, long-term data with, in which I know from historical data, I worked with this machine 12 years ago, in which I know it's very reliable hardware, extremely reliable hardware. Talking about like Japanese engineering. And of course, I want to have a machine, and I explained this thoroughly in part 1 of the webinar, which had many settings. I wanted to have large field of view, small field of view. I wanted to be able to use half rotation scan, like with 180 degrees. I wanted to be able to have a lot of control over my scan because I want to reduce those, not only those, but also reduce scatter, reduce motion artifact by reducing the possibility for the patient to move. And that's why having shorter scan times. But regardless, for me, it was impossible to even consider working as an implantologist or as a prosthodontist without having a cone beam CT scanner in the practice, because I was the only one in the city who had it. And it was considered crazy at the time, but it's the best investment I ever made. Because I mean, the price I paid for the scanner, I mean, I got it out or get it reimbursed like a long time ago. Why? Because I had the power to see. Like I said, I can do conventional impressions and I will get more or less the same results as the digital impression. I can postpone printing, but to have a cone beam CT, there is nothing to replace the image that the cone beam CT gives. And like consider this case in which the patient walked into my clinic a couple of weeks back, and the patient had a bridge, a full arch bridge, and she's been with the same dentist for more than 15 years. Same dentist, has a huge trust in this dentist. And she said, only now, like after 15 years, I feel a little bit of discomfort, like at the frontal area. And then now I made the decision to take a second opinion. Now, and I asked, like, I told her, like, did you go to the dentist when, like, for routine checkups? And she said, yes. And I said, did this dentist, like, may take any x-ray, given that you have a full arch bridge with lots of root canal treatments and probably one of the teeth are leaking? She said, no, just took like small parapical x-rays. Now, this dentist now is royally screwed. I tried to talk her out of it, but when I showed her this tennis ball or periapical lesion, this radicular cyst she has right now, she got pissed off beyond any recognition. It's like, I've been going for 15 years for the same dentist. You cannot blame the dentist for not taking the x-ray. But actually, that's in the past. Nowadays, unfortunately, our patients are not that forgiving as they used to, even if they are very well fed up, even if they are trained very well. She said, I'm going to sue them. Now, how can you explain missing a lesion this big? And there's not an incidental finding, which is like an isolated incident. It happens a lot nowadays. We live in a world in which our patients have access to a digital camera, which has better resolution than the digital camera I had 15 years ago, which was like this big, the digital DSLR. So you cannot afford to talk your way out of it, of an incident like this. Incidental findings, very simple case. It looks very simple, straightforward, edentulous case, and take a cone beam and boom, and then you see a terrible artery, a huge anatomical variation running through it. Now, what happens when you start drilling and you have no idea about this? What would happen, do you think? This patient will end up like Papa Smurf the next day. They could have hemorrhage. If it is in the lower jaw, they could die. Something happened to me. Almost happened to me. That's when I used to become. That's when I used to be a traveling implantologist. A case like this, in which I take lots of pictures, intraoral, edentulous case. I opened up, huge volume of bone, very simple case, nothing to be worried about. I mean, the chance of you messing this up is like close to zero. Very simple, lots of bone. And then this is what happened a couple of days later. You see huge swelling in the sublingual area. Now, what happened here? I missed an accessory canal, a canal which is called a paralingual canal, the one that you see on the right. And this canal has blood vessels. And if you go through it, you cut through this canal, it will induce hemorrhage. Now, I got lucky with this patient that he did not die in his sleep, because 8 people die from sublingual artery injury a year worldwide. So what happened? I mean, huge bone, the case has become a complete disaster. Had to refine it, remove the implants, take the implants out, and still did not survive. Disastrous finish. I have a complete denture now, and I have created so much fibrous tissue now in the sublingual area that I don't know how to solve it without going for a much larger surgery. This was like very, very long time ago. I got lucky. The patient was like, kind of understanding. But how many times do you roll the dice with implantology when you don't have a cone beam? How many times do you roll the dice and you just hope for the best? Because anatomical challenges, anatomical variations are everywhere. The thing is that I knew all of this many years ago. I knew all of this before I was a surgeon because I used to work in the radiology department. We used to see all those anatomical variations. We used to see like the lingual canal has a superior and inferior division. We used to have accessory canals, but you always think like this will never happen to you in practice. You always think that this will happen to someone else until it happens to you. And so that's for me was the reason, like after being through that, and I've been doing all those studies. This is a study I've done in 2005. I didn't even know how to raise a flap in 2005, but I was doing studies on cone beam CT scans and cadavers. And you can see like in the lingual foramen, you have lingual artery in 12 cadavers from 16. You have lingual vein, you have submental artery. You could have even a lingual nerve. You can also have a mylohyoid nerve going through the lingual artery. Can you imagine that, cutting through a mylohyoid nerve? You'll paralyze the floor of the mouth. This is a study. This is published. Type in my name, type Leon, and then you'll find the study. So you need to, like, what happened is that I became wiser. Like now I started to recognize dangerous areas. Like a patient was referred to me for all-on-4, in which the way to do it, usually with all-on-4, with cases like these, if you are not familiar with the procedure, is that this is a perfect all-on-4, because usually you extract the lower teeth and you reduce the bone and you will place the implants in an all-on-4 configuration. But look, when I took the X-ray, when I took the cone beam CT, look what I saw. You see like the mental nerve here, and then see like this beauty. Look at this. This is basically the arch of the patient. This is the jaw of the patient. Look at this. And if you are not very experienced, your first intuition would be, you know what, I'm going to reduce this like knife edge piece of bone, and then I'm going to place an all-on-4 in the residual bone. But what you're missing to see is the lingual artery, is the lingual foramen. Can you guys see the lingual foramen here? I don't know if you can see the cursor or not. The cursor is visible. I think, okay. But I think everyone can see the lingual foramen. This is the superior one, and then you have here the inferior one as well. If you do that, if you do a normal all-on-4 and you're going to cut purposefully through the lingual artery, this patient would die the same day, will die in his sleep the same night. So what you'll have to do instead is something almost unthinkable. Is actually try to reduce the bone just enough for you to do a bone augmentation to widen the ridge. And as crazy as it might sound, this is the correct way to handle a complex case like this. And this is, if you are, let's say, someone who has a lot of surgical experience and you're thinking that I can reduce the bone and place the implant in the residual bone, you'll cut through the lingual artery, whether you like it or not. It's a contraindication for all-on-4 to have a very thin knife edge bridge, like because you can cut through the artery very easily. So I used the piezo here. I cut the bone, but I didn't reduce the bone too much. I flipped it over, and then I fixed it to widen the ridge. And why I did that? Because I did not want to reduce the knife edge completely. Because if I reduce the knife edge completely, I run a much higher risk of cutting through the lingual artery, because I will have to raise a much larger flap, much deeper flap, and I will see the artery. I just didn't want to take that risk. As complicated and as difficult as this might look to you, this is much easier and much safer to deal with than doing the so-called easier approach, which is actually to reduce the bone so much, because to reduce the bone too much, to cut the entire knife edge and reduce it, create a flat plateau, it will mean you'll have to raise a much larger flap. It will mean you'll have to expose the lingual artery. Do you want to expose the lingual artery? I don't. I don't dare to expose the lingual artery. I'm a dentist, a prosthodontist. I have some surgical skills, but I don't have a hospital. I don't have an intensive care surgeon. I don't have a maxillofacial surgeon like at my disposal. So the correct way to do it is the way I did it, this way, in which you can see like I reduced the knife edge, but I used it to my advantage by fixing the bone and widening the ridge, and not actually reducing the ridge to the basal bone, which might seem to be the easier way, because I could recognize the lingual artery. And I could only recognize the lingual artery because I've been through that experience with the other patient in which he almost died. So this is an example of the importance of having digital planning. There is no way on earth you can do this without having digital planning. And I'm not talking about surgical guide. Do you see me doing surgical guides here? Not surgical guide. Digital planning has nothing to do with surgical guides. I do guided surgery maybe in 20–30% of the cases, maximum maybe 35. But I do digital planning in 100% of the cases. 100% of my cases are digitally planned. What does it mean? It means I take my cone beam, I take my Morita scan, I will sit down behind the screen, I have a cup of coffee, and I will virtually place the implants. I'll place all the implants virtually. I'll think about different scenarios. I will think about my prosthetic space. I will think about which abutment I'm using. I will think about depth. I'm thinking about, like, I'll plan the surgery in my head. And it doesn't cost money. I use Blue Sky Plan, which is a free software. I can do virtual planning for free. And I mostly print, if the case is too complicated, I will print out the model, and then I will practice the surgery on a model. There is no guide here. We're not doing any guided surgery. We're just doing digital planning, recognizing dangerous areas, recognizing dangerous landmarks, life-threatening landmarks. And all of this is easy. Now everything is easy. I have bone after 6 months, very good quality bone. I have a little bit of soft tissue dehiscence, which I fixed using collagen soft tissue graft, Eucoderm. And then after that, the case is solved. The case is completely solved. And this is something that I built upon many years to reach this level, not in surgery, but not in surgical skills. It would have been much easier to do an all-on-4 the classical way. And I might quite possibly not be here to talk to you tonight. I probably would have lost my lesson because the patient would have probably died. So visibility of anatomical structures on 2D slices, you need to understand what you're looking at. You need also to train. You need to read cone beam very well. I can read cone beam very, very, very well. And it takes a lot of practice. And you need to follow lots of intensive and thorough training to be able to recognize landmarks, recognize also anatomical variations in the landmarks. You need to understand where you have like the ducts, where you have the orbital landmarks, the condyle, the nerves, if you are doing bone grafting material, we did lots of research in which we did bone grafting, and then we took out the graft in animal experiments, and then we did a micro CT of the graft, and then we compared the volume of the graft with the Morita visualization of the graft, and it almost came 1-to-1. It was unbelievably well correlated. So the visibility of the graft is very important. I have now a dentist colleague of mine in the UK who has another machine, and he has a surgery scheduled on Tuesday, and he did a sinus augmentation 6 months ago, and he doesn't know if he's looking at a graft or actual bone. He doesn't know, and he doesn't know if he's going to place 6mm or 8mm implants. That all of this can be avoided if you start with good quality image. And if you start with good quality image, everything will fall into place. And good quality image is not something that can be just stated as good quality. It needs to be something substantiated, something which has lots of history, lots of research. And we've done many, many studies recently as 2021. Even during the Corona period, we still continue with doing Morita studies about bone quality assessment, being able to visualize trabecular bone, being able to visualize the quality of the bone, saying if it's bad quality, good quality, type 1, type 2, type 3, type 4, are you going to undersize the osteotomy? How much are you going to undersize the osteotomy? You need all of that. When we did comparative studies and we asked 20 dentists which image you preferred, most dentists said, I prefer image 5 and 11. And 5 is a multi-slice CT, and 11 is a Morita, the 3x4, which this study is like more than 10 years ago. You need to check the quality of your 3D segmentation. All of this needs to fit, because you need to have very high resolution image to be able to do anything meaningful with it, not only something which looks pretty. And most people cannot distinguish between a 3D model, a surface which they have to segment, which mean isolating the bone from surrounding structures, and volume rendered images. Volume rendering is just a way to visualize your image. And many software packages with many systems, they make it look very pretty. The image looks nice. But once you really segment the bone, segment the image to try to make a surface, which is the only thing you can use to be able to match with an intraoral scanner, you'll see huge variation in image quality, because the matching between or registration between a cone beam CT scan and intraoral scan is entirely dependent on the quality of the 3D segmentation of the teeth. And we've done this a study many years ago, like in which we did a cone beam CT scan, we did a micro CT scan, we did a Morita image and micro CT scan, and we saw like the differences were very, very little when using the very high resolution field of view, the small field of view. So this has like lots of consequences for everything, from visualization of root morphology, for pathology, for visualizing root fracture, the ability for you to visualize root fractures. You need to have different field of views. You need to have a large field of view for doing everything, from doing the one I have. I can visualize from 15x14, which is from condyle to condyle. I can do zygomatic planning, but I can also zoom in with a 3x3 or 3x4. I don't remember exactly, like 3 or 4x4, and then I can visualize root fractures. You need to be able to zoom in, and you need to able to zoom out. And this we've done also with many researches that when even did root canal for root analog implants, in which we did the cone beam CT scan, Morita scan preoperatively, and then we designed a root analog implant, which we hammered in. It's like it was an alternative to standard implant placement. Also publications from 2016. All of this relied on accurate segmentation of the cone beam CT data. And accurate segmentation of the cone beam CT data relies on good image quality. And good image quality relies on very reliable hardware, but also you as a user to be able to modify and tweak the settings to get the best image for the kind of indication that you have. And we did this for everything. Like I said, we zoom in, we zoom out. We did this for TMJ imaging, for doing osteophyte formation, also for arthrotic patients as well, arthritis. We did this for cephalometric. You need to have also very good soft tissue visibility with cone beam CT scans so that you can match if you're going with facial scan. And then basically you can start doing like DSDs, 3D DSD, and then you can visualize like the soft tissue. You can do a virtual mock-up, like for a case like this, in which nowadays we can do something like I just showed you, like you can do a facial scan, and then you can match the facial scan with the cone beam. You can also use a jaw motion tracker so that you can actually apply the motion, the actual motion of the patient on top of the cone beam CT scan. And then you can do your digital planning, like for a case like this, in which the patient came to me for a second opinion. And she told me, I went to my orthodontist, and an orthodontist said, you need to have a BSSO operation. If you are not familiar with the name, it's a bilateral sagittal split osteotomy, which is basically to cut the mandible and to move it forward to resolve the open bite. And I said, well, I'm not an orthodontist, I'm an implantologist, and I'm also a prosthodontist. Let me have a look, see if this is actually something that we can solve without doing this very invasive surgery. And basically, this what we did is I did a large field cone beam CT scan. We did the segmentation of the bone, and then I did a virtual setup for the patient, and even the chewing function. I said, like, okay, this is how you chew. I just want to see if the condyle actually has enough space if we do an anterior mandibular rotation, or let me see, like, what is the functional space that you're using for the chewing function. And once I know the functional space, I know, like, is it possible for the maxillofacial surgeon to advance the mandible, or is going to do a disaster? And the simple answer is that it's going to be a disaster if they advance the mandible here, because she needs this chewing function. She needs to have this envelope of chewing, basically. She needs this prosthetic space to chew. If you're going to close the overbite with her, just to prevent relapse of this lateral incisor going inclined lingually, you're going to close her, but you'll make her like Clint Eastwood, like, she'll have to speak through her teeth. And this is really something that can only, let's say, made visible if you do proper planning. And I told her, like, your orthodontist, does he have a cone beam? And she said, what's a cone beam? I said, did he make a 3D image? And she said, no. He took pictures. He took many pictures. And I said, like, yes, but I also can take many pictures. But unfortunately, we can't come far with taking intraoral pictures and light photos. You need to visualize. You need to see. And it's really stupid not to do it in 2024 when we have access to so much technology. This segmentation of the bone, like to be able to visualize this skull, this used to be computationally very expensive, and also you need to send it to a company to do the segmentation for you. And now this is done with AI. This is free. This is basically free. I only paid for making the digital smile design, just doing the DSD. So it's really risky, and is really very irresponsible that try to, in 2024, not to take advantage of all the digital modalities that we have. I can clearly see that she will have problem if she closes the bite surgically in this case. And I can also clearly see the distance we're talking about. If I do veneers, is going to be very little. The chance of relapse is also very little as well. So all of this depends on how accurately can you match an intraoral scan with a cone beam, which also depends on something we researched in 2017 with professor with Dr. and she's now a Professor Flügge in Freiburg. In basically like you need to start with good quality image. Even for dentate patients who have no restoration, you need to start with good quality image, good quality cone beam, good quality intraoral scan to have very good matching. Because if you don't have good matching, there is no good analysis that coming, because you'll have an error that will build all the way through the digital workflow. So, and talking about guided surgery, more or less the same thing. All of this depends because the guide is made to be supported on the teeth from the intraoral scan, but the position of the implant is placed on the cone beam. So you need to have very good matching. And you can have any fancy, sorry, excuse me. You can have any software you like to do the planning, but when you have a very thin ridge and we are coming very close to the nerve, that's basically when you'll see the difference between a very good machine and very good workflow and a bad machine and a bad workflow. Because like when you have a lot of bone and you have a lot of height, it doesn't matter which machine you use because you have a lot of margin of error. But when you have a very thin bone and you're placing an implant very close to a nerve, every like 1/10 of a millimeter count, because you have a cumulative error that will is the CBCT, is the intraoral scan, is the 3D printing, is the digital planning, is the tolerance of the sleeve, is the components they're using. All of this will accumulate together. So sometimes I place implants guided just because even though I can do them, let's say unguided, I can see like the case might be less forgiving. Like if you look which implant is placed guided in this case, is not very clear to you, but for me it's very clear. Is of course the lower left canine. Why is this guided? Because like I have much less margin of error for this lower left canine, because canines are terrible teeth to begin with if you do them immediate, and this was done immediate. In which I had to pull out the canine. I have a very long root and I need to go very deep. So the margin for error is much less. While in the upper arch, I did it freehand because I can place implants. I'm an implant surgeon. I can place implants. I can place implants perfectly parallel to each other with no guide. But this, I can do it in the upper arch. Upper arch is much more forgiving. I can go through a sinus. I don't care if I perforate the sinus a little bit, but try to go deeper into an area like the lower canine where you can perforate lingually and you end up in the lingual space. Patient can bleed. Where you can also perforate the ventral nerve of the ventral branch of the mental nerve. So why guided surgery? Because this really doesn't have to happen. I mean, I know like some people are very good in doing root canal treatments, but if you are, let's say, inexperienced in doing surgery, might be a good thing, like, you know, to at least learn how to place an implant parallel to the root and not parallel to the crown. This implant was not badly placed by the guy who placed it because in his mind, he's placing the implant parallel to the crown. And then basically in which you have cases in which the crown is a little bit like stuck vertically, but the root is very much inclined. It's very difficult to follow this angle, especially if the guy is right-handed. Like it's easier for me because I'm left-handed to do it on the lower left. free hand, but if someone is right-handed and they are standing on the other side, they have no visibility. So I'm not quick to judge, but sometimes really you need to have guided surgery just because such mistakes really cannot happen, cannot exist in 2024. This is 24. This is not from 20 years ago. This is this year, happened by a colleague who places implants. Not too many, 60, 80 a year. It happened. And it should not have happened. But, you know, like most of our elderly colleagues, they are relying that they know the patients for many years, so they can get away with it. But it's not really good dentistry, is it? Why digital planning? Because one of the largest disasters that happen is when you place an implant in the lower second molar region, when you have a very deep concavity and you try to place the implant prosthetically driven, like the guy who did it like this, in which you're very sure you're placing the implant perfectly in line with the first molar, and then you are perforating the submandibular fossa. Imagine this case. This is a real case. I did not make this up. This is a real CBCT scan. Imagine someone drilling with the pilot drill, going through the submandibular fossa, and then going through with the second drill, with the third drill, 3 times perforating, and then placing the implant, a very long implant, mind you. And in his mind, he's doing a good job because he's going for a prosthetically driven and not the anatomic reality in which you need to augment the bone. But I always say implantology surgery is surgery. Learn to manage complications before learning to avoid them. Just because I'm good in doing digital, it doesn't mean I will have no complications. I had a perforation here in the sinus, but I took the wall, the cortical wall, and I put it upward to close the perforation, and I reinforced it with a resorbable membrane, and then I continued with my augmentation. So I like always say implantology is surgery. Learn to manage your complications before learning to avoid them. Digital planning is about avoiding complications, not really managing them. You cannot really manage complications with digital planning. You can only avoid them with digital planning. But you also need to learn how to manage complications if this is not something. But the problem appears when people rely too much on their ability to manage complications that they don't really avoid complications. They don't really feel the need to avoid complications because they are very good in managing them. That's also bad. That's really bad. So there are main decisions, like, you know, the decision to augment. When I look at cone beam like this one, sometimes I don't really know. This is a patient who had a tumor in which, like, the maxillofacial surgeon told me that, can you place an implant? But I had a decision to augment. I could place the implant in residual bone. Yes, I could. I could do also augmentation, GBR with the implant placement. But it was much safer here to do augmentation because this patient is young. This patient is also a grinder. This patient is expected to live for another 40, 50 years. So if I would go for a more sustainable solution, the best solution, and also this patient, as it happened, is a lawyer. I said, look, you're a lawyer. I just want to see you in my room. I don't want to see you in court. I'm gonna go with going with an augmentation in this case, with this augmentation, I'm increasing my chances of being able to place the implant in an ideal position and having also enough width, enough buccal attached gingiva. I have enough like buccal tissue so that it will support the implant in long term. We do bone augmentation with this is a cortical plate, which is an allogenic graft plate. We did the augmentation, and then you can see after 6 months, then you will have sufficient width of the bone. And then we will remove the osteosynthetic screws. You can see, like, I mean, in this case, I did do guided surgery in the beginning, but it has very little mouth opening, but I could go with the free hand afterwards because I couldn't go with the surgical guide. You can see, like, I'm doing digital planning. I'm not really talking about guided surgery. I'm planning my cases. I'm thinking about the consequences long term. I'm thinking about what will happen to this case in 10 years time, 20 years time, because this is like what people expect with implantology. They expect long term. It's a long term business. It's a long term game. So in a nutshell, we're saying why digital planning? Because really these things don't have to happen. I mean, if you look at the image on the right, you'll see this is a perfectly placed implant. It's prosthetically driven for a screw-retained restoration. But the patient complained of pain for 2 years. And then every time she went back to the dentist, he prescribed antibiotics, and then he sent her home. And he said, I cannot see anything, because when you take a panoramic x-ray, you cannot see anything on this case. But then when I took a cone beam and I told him, like, yes, you have a very good dentist, a very good surgeon, but he's a very bad prosthodontist. And she said, how so? I said, like, he wanted to go for a screw-retained restoration. So he did prosthetically driven. If you look at the placement of the implant, it's perfect. But the anatomic reality is that the bone is extremely, extremely undercut. Many people start doing implants in the premolar region. They think that the premolar region is actually the easiest way in the upper jaw to start with. It's actually one of the worst places to start placing implants because the bone is always undercut. I said, like, so what would have been the alternative? I said, the alternative is to place the implant this way, to place the implant completely wrong prosthetically, place it deep inside the bone, and then correct for the implant position using an angled abutment. You can use custom abutments. You can use angled solution like ball screws. There are, if you only know if you only know the surgery, you only know half the story. If you don't know and understand the prosthetic, and this would not have been necessary. But I had to do this here because two implants need to be removed when you raise the flap, and then you see like the thing is completely exposed. And this spurt of blood, this is the posterior maxillary artery, which we just cut. So this is the anatomic reality that we have, which we could have been avoided very easily if someone just really thought about making a cone beam CT scan beforehand. I always say, make a cone beam CT scan before the treatment instead of make it before and explain instead of making the cone beam CT scan afterwards and apologize. Because you have the two choices you have. You can make it beforehand and explain to the patient what will happen, or make it afterward and apologize. So that's basically digital planning, is because you need the prosthetically driven mind to have, like when you have the scalpel in your hand, you have the prosthetic in your head, but at the same time, you need to realize the anatomic reality, the surgical reality. Like there's no bone for a prosthetically driven screw retain restoration. But if you don't know that you have also angled tie base, and you can also do this case very easy with an angled tie base, also screw retained, or you can go for a custom abutment and do it cement retained, you end up with a situation like this. So digital planning is important, is really, really, really important. I have hundreds, maybe more than 1,000 of cases documented in which I need to augment the bone, not because I'm lacking bone, but because I'm lacking bone where I have what I need my prosthetics to be. So even though I have enough bone in this case, and even though this is thin, it's not about thin. I need more bone in this case, because the digital planning I have is requires me to place the teeth more buccal. So I needed to go for a sinus. I needed to do horizontal bone augmentation, even though I could have placed the implants more inward and gone for a screw retainer restoration, but the aesthetic arch of the patient, the digital smile design, did not allow this. When I presented the case with the teeth very much inward, they were prosthetically very well, but the patient said, I don't like them because when I smile, my buccal corridor is too much. I see a lot of black triangles on the right and left side. So I went through this monkey business just because the patients want to have a better aesthetic arch. And that's what's required. That's digital planning. Do you see me doing guided surgery here? I'm not doing guided surgery. All of this is digital planning. It's all cone beam. Like I always say, I don't really do guided surgery for every case, but I do digital planning for every case. Every case, I sit down, I have my cone beam, and I digitally plan it. And that's the arch the patient wanted. This is the digital arch. Like when I'm going to argue with the patient said, my front teeth are protruded. You'll make the rest of my arch in this way. What am I going to do? I said, pull out the front teeth. We'll do all on four. I said, I don't want to have all on four. I have my front teeth. I like my front teeth. I said, I'm going to hurt you. I'm going to build a bone. You're not going to like it. He said, I don't care. You're not going to pull out my front teeth. And I want to have molars. So they signed for it. And then basically once you have that one, you have now augmented the bone. And now you have the required surgical space. You created the surgical space because these implants need to be placed more protruded, more toward the outside. And now you can go for guided surgery. Now I can do a guided surgery because my homework is done. I did this case even a flapless. I did flapless. I did a puncture, soft tissue puncture, removed the soft tissue, and then we started doing the drilling. And I'm drilling in between the osteosynthetic screws. See, like how much faith I have in my guided surgery because I understand this is tooth-supported guide. It's a guide which is supported on remaining teeth. It's very stable. I know the tolerance of the guide. I know the tolerance of my sleeve-in-sleeve concept. I still prefer using the handles sleeve-in-sleeve better than doing the ones which have no handle because this is very precise. And I triple checked my osteotomy. I need to check that I actually drilling correctly. I'm drilling the right space. I'm placing the implant to the correct depth. And I need to feel that the torque is building up. I do not mind finishing the case manually. I don't have to do everything digital. It doesn't have to be completely 100% fully guided. If halfway the procedure, I see that the bone is soft or I need to over or undersize, I will take over because the reality is that I need to guide the guided surgery. The surgery is a tool in my hand to guide me as an experienced user, but it's not for me to compensate for my lack of experience. So, and then once I have it, then it's done. You know, the patient has the implants in the correct prosthetic area, prosthetically driven. I augmented. He paid more for the augmentation, but he wanted this. The patient signed up for having the teeth, having the prosthetic arch done this way. He said, this is my smile. This is where I want to have my teeth. And that's basically the reality. He said, like, this is the smile I have. Like the front teeth, you can build them up with composite afterwards. And we did that for him as well. But this I could not have done with a conservative approach with all on four. By placing the implants where I have the bone, I need to have prosthetic planning. I'm just showing you that there is like not one size fit all for all kind of cases, but for all those cases, there's only one common theme, is that I sit down and I do digital planning. I'm not talking guided surgery. I'm talking about digital planning. For surgery, you need to have three things: IVA, elimination, visibility, and access. And guided surgery takes away actually all three. You lose illumination, you lose visibility, you lose access. And that's why, like I always say, guided surgery is the last technique for you to learn, not the first one. Only like when you've done many hundreds of implants, then you learn guided surgery. But you should learn doing digital planning from your first case with cone beam CT scan. That's the difference. The first example of guided surgery is basically when you have a case like this, in which you are doing flapless immediate loading. So doing a soft tissue punch, and then you're drilling your osteotomy to the required depth. That's basically like the easy case that you can have. Always checking that you have enough depth. Check the depth, double check always. And then once the implant is placed, you need to feel like, the torque is building up, and then you have reached the required torque. And then you'll see like here, I'm reaching the required torque, and then, it's going to stop by itself. If I have reached the correct depth and I've drilled the osteotomy and I've done my planning, you see like my handpiece will start rotating with me because the torque is building up. And now it's built up. Yeah, sometimes this happens. That's, you have the implant in place. I place an abutment, doing a universal abutment in this case on an edentulous system. And I'm using an abutment level workflow. Then I'll put the scan body on top of the abutment, and I will scan from the abutment itself. And basically that's the implant, and then that's the crown. So that's the first type of guided surgery that you can consider doing, which is flapless immediate loading. And this is for single crown that we had, but you can also do the same thing for like multiple implants as well. This is a mucosa supported guide. So the guide is support on top of the mucosa. I don't like to use fixation pins. I have my reasons for not liking them, but we place the implant fully guided, flapless, through the mucosa supported guide. This is a relatively easy case. I have a lot of margin of error, so the bone is quite wide, and then we place the multi-unit abutments. And after that, we will start we do the multi-unit with like angled multi-units, so that basically we will be able to correct for the angle of the implants. And then we take a reline impression with the denture. And this is a special scan body called OptiSplint from Digital Arches, which we use for immediate loading cases where there's a lot of blood. It's difficult to scan with the normal scan bodies. So we use those scan bodies in which we splint them together and using like a honeycomb metal mesh. And then we scan them like we light cure them, and then we scan them extraorally. And we will touch on this subject also in the third webinar in-house manufacturing, because we'll show like the process we're doing for in-house fabrication for full arch cases. And then this is like the design of the Dolder bar in this case. And we designed the bar, and then we can design the denture. And this denture can be provided within 24 hours, an immediate overdenture. We have many of these in the Netherlands. We also do, of course, fixed restorations, but I want to show a bar case because I think this is more interesting to show a situation like this. So you can, we have a mill unit, we can mill the bar within 24 hours. Then we can deliver the final restoration. tighten the bar, and then we check the fit of the denture, which is milled. Then we have a retention silicone that we place inside the denture, and then we will place it. And if all the digital planning is done well, then you have very good occlusion as well. So that's the case. To do immediate flapless, immediate loading flapless in a heel side, and becomes more complicated when you do guided surgery with digital planning if you do have flapless immediate placement and immediate loading. So you have a tooth like this one. If you extract it, you end up with an extraction socket. An extraction socket is, of course, a higher risk because you're drilling the implant, you're placing the implant in an extraction socket. So, and you're dealing with periapical infection or fractures, or if you don't have a buccal wall, which is completely intact. But if you have a very good cone beam CT image, even if the patient has lots of zirconium crowns, you can have a very good matching between the intraoral scan and the cone beam CT scan, and your digital planning will be completely accurate. And then you will be able to place the implant with full confidence that it will go exactly where you planned the implant to be placed. And then once the implant is in position, I always, if I have an extraction socket, I try to be at least like 2 to 3 millimeter deeper than the zenith of neighboring teeth, and of course within the level or a little bit even apical from the level of the buccal cortical plate. And then we fill in the space between the implant and the cortical plate with xenograft. This is like a standard GBR. And once this is done, then you can remove the cover screw again, and then you can place you can do the same thing. You can place the abutment, and then you can scan the abutment as well, like we demonstrated in the previous case. And then you can have immediate loading done within a couple of hours, and then this does the healing that you have within 2 weeks. So very predictable guided surgery, but it all depends on having very good image to start with, because if you don't have a good image from the cone beam, even if you match with the intraoral scan, you'll have an error there. If you have an error there, you'll drill in the wrong position. If you're drilling in the wrong position, everything that follows is wrong. So, and this can be done the same thing, like you can do immediate placement and immediate loading for multiple teeth, like a felled bridge, like this one, in which you can extract multiple teeth, and we keep some teeth strategically placed, because even if they're lost, because we want to support the guide on teeth, because tooth-supported guides are better than mucosa-supported guide, more accurate than bone-supported guides. So even if we have like 2 hopeless molars, we keep them to support the guide. We place the implants, and then after that, we extract the molars. And then you can see we can do temporary cylinders, and then this surgery you can see on Triodontics. We have it posted. So guided surgery, like when I say like when you start with, I always suggest that you start doing guided surgery not the way I did or I demonstrated, not doing flapless, not doing immediate placement and loading. Really try to do guided surgery with a flap, because with a flap, you'll have visibility, access, and illumination. Because if you don't have visibility, access, and illumination, then it's really tough if a problem happens. So if you're not familiar with guided surgery, raise a flap, because once you raise a flap, you can see better. Like a case like this, in which it was easy to raise a flap because the patient had a failed GBR, so from another clinic. So when he came to us, I needed to raise a flap anyhow, because I needed to remove the old GBR. I mean, I am experienced enough to do guided surgery flapless, but If I have to raise a flap, I have to remove an old bone augmentation, I will remove it, of course. So in this case, we remove the old bone augmentation, we place the implant, we did a new bone augmentation, we fixed the augmentation with titanium mesh. In this case, we did membrane, and we sutured, and we did temporary. I never do immediate loading with bone augmentation. And then this is how the case is finished. So always say, like we say, is that try to do guided surgery with a flap, because you'll have more access. And if this guided surgery doesn't work for you, then you can take over. And again, why digital planning? Because these mistakes really do not have to happen. This is maybe the mistake on the right is really something that doesn't happen quite easily, but you'll be surprised, like even in people who are experienced, they have a lot of faith in their abilities, that they drill deeper and they are just not seeing what they're doing. And I have lost count of how many cases I've seen when I take a cone beam CT scan and I see a lingual perforation like the one that you see on the left. And in the Netherlands, we have lots of edentulous cases. And then if you take most of them are done without cone beam, unfortunately, but this is now changing more and more, because the new generation we are teaching, we're saying like, you're crazy if you do an edentulous case without taking a cone beam. But we used to have lots of Straumann cases. And luckily for Straumann users is that the apical part, the tip of the implant, is like very smooth and like it's very rounded, like a bell shape. So it's not an invasive tip, which cuts like and induces bleeding or induces nerve damage because it presses down when you place the implant. But now most people are using bone level implants, which are like very tapered, very aggressive threads. So you cannot get away with a case like the one you see here on the left. And sometimes, you need to understand like there is a lot of nerve damage that happened, and then the nerve need to be transposed. How would you able to see this without having a cone beam CT scan? So some cases, if you don't have a cone beam, you're really playing with fire there. And the last thing we're going to be discussing tonight is like the surgical templates. There are basically, when you're talking about like conventional guided surgery, static guided surgery, we have three types of guides. We have the bone supported guides, which are like directly supported on the bone. You have the guides like one I showed you, which is supported on the mucosa with the Dolder bar case, or you have the guide which is supported on the teeth, in which you have like a remaining dentition. Teeth supported guide by far are the best, are like the most accurate if you have a good cone beam CT image and good intraoral scan. And mucosa supported guide and bone supported guide are less precise. And of course, when you're talking about guides, you're talking also about sleeves, which are like the little metal cylinders in which like the drill goes through. And you need to understand, if you have like a small medial-distal space, you need to have a very small sleeve. If you have, let's say, you're missing one premolar and one molar, then you will need to have a medium sleeve for the premolar area and a large sleeve for the molar region, because you're placing a larger implant. And if you are missing a lateral incisor, like in this case, then you need to have a very small sleeve, which is like the purple one, at least with the system I work with, the Neodent system. So I said I still prefer the handle system because it allows me to use the 2mm drill. But most systems have switched now to handleless, but I don't like the handleless because you go immediately to 3.5mm, and I undersize the osteotomy in many cases because I use immediate loading protocols. But you need to understand that guided surgery is much more than just doing digital planning, because you are working with much longer drills. You're not working with the drills which are like 10, 12, 14, 15mm. You're working with the drills which are 23, 24, 26mm, because if you look at the drill on the lower left side, where the 8mm is, the first line is actually 80 millimeter. Why? Is because you need to count 4 millimeter for the gingiva and 5 millimeter for the thickness of the sleeve. So you already have 9 millimeters before the drill hits the bone. So like the case I showed where you have bone augmentation done, the lawyer lady, I couldn't do guided surgery because I had not enough mouth opening for the guided surgery. So I did digital planning and guided surgery, and then I threw the guide in the garbage because I couldn't ask her to open her mouth that much. So that's also a good tip for you to remember. Always patients need to at least like 3 fingers inside the mouth for doing surgery to begin with. And if you have guided, you need at least maybe like 3.5 because they need to have like a crocodile opening before you'll be able to fit a surgical guide inside. So surgical templates, the tooth-supported guides, and there are like more than 3,000 publications on guided surgery. Tooth-supported guides are statistically significantly greater, more precise than bone-supported guides or soft tissue-supported, mucosa-supported guides. Bone-supported guides are getting back in fashion because of AI, which is now segmenting very well if you have good cone beam CT image. So having more and more faith in them in complicated cases now, because many hopeless cases you cannot use the teeth anymore, unfortunately. So, but in partial cases, always, of course, guide is supported on the remaining teeth, and you're doing digital planning. You're having like a cone beam CT scan, and you're having an intraoral scan, and you need to match the cone beam with the intraoral scan because you're not designing the guide on the cone beam, it's designed on the teeth. And of course, the teeth with an intraoral scan are much better than the teeth with a cone beam because there is no segmentation error, there are no artifacts, there's no metal. But you need to have very good quality cone beam CT scan to begin with so that you can have very good matching between the intraoral and the cone beam. And that's where the difference lies between a good CBCT image and a bad one. Because any artifacts, like this is something which happens quite a lot. If the patient moves, then the whole thing is just basically screwed. If the patient moves, then you'll have like double lines and double image, and then you'll not be able to match. And why do patients move? Because patients breathe and they swallow. And swallowing and breathing are your biggest enemies when making cone beam CT scan. And that's why I like and I love the Morita because it gives me the option to have half arm rotation scan, which is 180 degrees, meaning I have the scan time. I don't spend 15 or 20 seconds scanning. I spend 9 seconds scanning. And this is basically like when I have 180 degrees, like half arm rotation, I have much better quality image than I have it if I have a full arm rotation scan. And if you do not know what I'm talking about, that means that you haven't watched part 1 of the webinar series. Then go back and watch part 1, and then you'll understand because I explained this in details there. So once you have this, then you'll do your setup, and then basically you'll do your digital guide design where we have like remaining dentition. We can support the guide on remaining teeth. We're doing extraction, so it's an immediate loading case. We are positioning the implants, and then this is the surgical guide doing with the sleeves. So accuracy of guided surgery, it depends on the position of the guide, depends on the guide fixation type, like I said, tooth or mucosa or bone supported. Depends on the flap approach. If you're doing like flapless or if you're doing flap, but usually, like we say, a totally guided system using fixation screw with flapless protocol has like the highest accuracy in partial cases, but I don't really like it because once you commit to these pins for fixation, you have no chance of taking over the case if you need to handle complication. So I don't like those pins, but the literature tells you, of course, if you fix with pins and place the guide and fix with pins, is really very precise. Guided surgery is amazing. And this case I showed briefly in my last webinar, and I promised that we will discuss it in details in this webinar. This is a case which we did in our implantology master program. And basically, you can see it's a very challenging case because you have difficult cone beam CT image. And I always love to show this image because this is the reality. This is a patient who has bridges, has implants, has like no natural remaining dentition, maybe like 1 or 2 teeth. Of course, you're going to have artifacts. Morita is not magic, but the idea is basically if you have a very good look, you will see if you take a look at the axial slice on the upper left side, you see that even though this patient looks horrible on the volume rendered image with like shaded bone in this preset that I have, if you look at the 2D scan, you can see actually the metal artifact is very little. I can see the border, the outline of the zirconium bridge very well. Now, in the old days, there was no ChatGPT. There was a PhD student called Bassam Hassan, and in the department university, working in a dark room, no lights, no windows. And he used to work like a donkey day and night doing segmentation by identifying those borders manually. And that took between 6 to 8 hours per segmentation for me to get a good 3D model that I could match with an intraoral scan. That was my PhD thesis. And now, as it pisses me off, unfortunately, AI does this within 2 minutes because, I mean, there used to be companies. Basically, you had to send the image to them, so they did the segmentation for you. And now AI does this in an unbelievable fashion. Even if the image is bad, as long as you are, AI is also not magic. As long as the AI can see the border of the crown, like I see it, like you see it as a human, if you can see the border of the crown on the image, AI will see it and it will segment it. It will isolate the teeth. And when you are looking for a cone beam CT scanner, you are looking for this. You're not looking at the beautiful, perfect scans of young 20-something who don't have any one filling in their mouth. This is a real case. This is the case that separates an excellent scanner from a good scanner from a bad scanner. Why? Because if you cannot see the border of the crown, there is no way to see it in a 3D for you because the algorithm, the way it works, it will never be able to recognize it. But if you can see it on 2D slice, this beautiful outline, no motion artifact, no overestimation, no underestimation, this beautiful outline, if you can see it, nowadays, AI can see it as well. This used to be my work for 8 hours a day, for 3 days to do segmentation, for no pay as a PhD student. And now AI is doing this in 3 minutes by itself. So now when we come to the mouth, is this accurate? This used to be a very difficult case to do, a case like this, because this is a zirconium bridge the patient has. If I have poor image segmentation, if I had a poor cone beam CT image, and I have poor image segmentation, even if I have perfectly made surgical guide, the guide would be shit because the implant position is wrong, because the matching between the intraoral and the cone beam will be wrong. Let's have a look. I'm raising a flap because this is, even if it sounds like a simple case, I could not trust the cone beam and the intraoral scan and the surgical guide and the software. I wanted to see, I said, this is like almost impossible if we have come this far with the technology. Even though I knew everything to be done with this case, I just could not accept it mentally that this is going to work as good as it did. And it's just my limitation. It's basically for me, I just want to see. I opened the flap, was totally unnecessary, but I opened the flap because I said, there is no way that the matching between the intraoral scan and the cone beam CT using AI matching is that accurate. But holy crap, it was unbelievably accurate. It was gorgeous. And that was for me, let's say, a turning point in which I realized, okay, yes, I mean, we came this far. It took maybe almost 20 years, but we came. We're here. We're here now. We can do guided surgery to this level of precision, in which I have a terrible metal artifact. I have terrible zirconium, metal fused to porcelain artifacts. And just because I can see the slice on the cone beam, the AI could see it as well. And it did a beautiful segmentation. Guided surgery, we're making here a 3-unit bridge. We did a digital smile design for this case. We did GBR, and you can see, boom. I mean, yes, this is not really human. I mean, this looks fake. To have implants this parallel, they look machined, but that's guided surgery nowadays. So that's actually where we are at with partial cases. Good quality image, good quality cone beam, good quality intraoral scan. Well, may I dare say good surgeon as well. Then you'll have predictable results. Yeah, basically it became like very simple. I mean, like now we scanned, made a temporary bridge, and bridge placed, and then we're done. Temporary bridge placed, and then did like a coronally advanced flap because I want to keep the gingiva on the lateral. That's a trick we do. We did, of course, the DSD, everything. You can see, like, why the teeth were extracted in this case. You can see, like, the periapical infection, short roots, and you can see, like, the healing after 2 weeks. And it's, like, on the upper right side, and it's, like, almost nothing, like you've done nothing, basically. So guided surgery, it's amazing if you understand that it all starts with your cone beam. Remember always the principle of GIGO in medical imaging: garbage in, garbage out. You have to start with garbage information in, you end up with garbage result. That's not me, that's like medical imaging principle: garbage in, garbage out, GIGO. Start with good image, then everything will follow through. Intraoral scans, they are like mostly now good. 3Shape, of course, is king, but mostly other scans are also good. They are there. Cone beam, for real cases, you really need to have 180 degrees. You really need to have to be able to control your field of view. You need to able to control your settings. Not many systems have so many options. In my opinion, is the best. And it's the best because it's reliable hardware, but at the same time, it gives me very high quality segmentation. This is not me. I did not segment this bone. AI did that. And for AI to do this, it needs to start with good quality image. And then you can have unbelievable results. But again, best image, best AI, best intraoral scan. So there are situations in which guided surgery, even for simple cases, are just impossible to do, because you need to understand, you need to have special dimensions for the sleeve to be able to drill your hole. Like in this case, in which the patient wanted to have, he missed 4 teeth because of trauma, and I planned the case and placed implants at position 1, 2, and 2, 2, lateral incisors. And I couldn't place any implants in the front because there is no space for them, a large incisive canal. I forgot the case. And then someone else, a colleague of mine, he sat down without me knowing to plan the case because he's working in our practice. He planned the case. He also planned 1, 2, and 2, 2, only 2 implants. When I came on the day of the surgery, the patient said, I said, look, I mean, we discussed 4 implants. I really told you 4, but I really can only place 2 because of I need to have those implants placed in those 2 guys. If I use the guide, then I will not be able to place 4 implants. And he said, I said 4. It's 4 or I walk away. And it doesn't matter how good you are. If you understand that you need minimum thickness for the surgical guide for the sleeves, but you also need to have space between the neighboring teeth and the sleeves, there is no way of doing 4 implants in this case because the nasopalatinal canal is very, very large. So I couldn't place 4 implants in this case using guided surgery, although I had a very good planning. But I said, okay, I can do it without the guide. I'll place 4 implants, but without the guide. He said, I don't care about the guide. You do what you do. I want to have 4 implants. And then that's basically, like I always say, you need to be a good clinician to do what you're doing. Oh, this movie is not working for some reason. Oh, I apologize for that. But basically, we could place 4 implants here. Let me see if I have it. Okay. Always at the end of the webinar, something happens. Okay. Well, I apologize, I don't have it, but I'll put it later on. But I could place the implants, 4 of them here, but I don't know why the media is not working. It's playing now. Okay, good for that. Okay, so sometimes I have to overrule my digital planning, in which I couldn't be able to place the implants with a surgical guide in this way because I need to be close, like really minimally close to the neighboring tooth. I'm barely keeping the 1.5 millimeter distance. Somehow I think the computer is overheating. Too many surgery videos. Okay, so this is the first implant. Let me see if I have it here. Well, guys, this like always happens when you're doing something live. For the first time ever during a webinar, my computer froze. Oh, can you still hear me?
I just wanted to say, at least you are still there. It doesn't matter if the slides don't work. No.
Okay. Well, we'll go very quickly because I think even my PowerPoint is telling me to go home because the football match is about to start. But basically, sometimes you'll have to like override the guided surgery. And because I couldn't do this with guide, because I couldn't do it with sleeves and with 3D printed guide, because I need to have minimum distance for the sleeve and for the guide. But I could do it freehand. But I'm having like the surgery in my head and the prosthetic. And the implants were placed this way. And I could restore them the same day. We did custom abutments and 3D printed resin. We placed the custom abutments and we placed the teeth this way. So I think I'll skip the last video. I will basically, I see my computer is freezing. I would like to thank everyone for attending, and I would welcome any questions if you have any.
If there aren't any, I want to thank you very much, Bassam, for this interesting second webinar. We will put up the video on the Morita YouTube channel for all of you to watch again if you like. Please also sign up for the third webinar with Bassam.